Welcome all. Today, we'll discuss about gastroenterology topics part 2. We'll start our discussion with inflammatory bowel disease. Whenever you see the term inflammatory bowel disease, you see it is inflammatory. So the patient will have pain inevitably. Pain with diarrhea in young patients, irrespective of the body weight, please select the inflammatory bowel disease as the most important cause. You'll have to make sure that the patient has got a colonoscopy, patient has got fecal occult blood testing. You'll have to think of ulcerative colitis. You'll have to think of Crohn's disease. You'll have to think of primary sclerosing cholangitis in association with ulcerative colitis. Usually, for ulcerative colitis, the stem goes like this. The patient is a male patient, a 32-year-old male patient, is a Jewish patient, and patient is having age of 32, or patient can be having 55 years old as well, because ulcerative colitis has bimodal distribution. Most important thing you'll have to remember. Sometimes questions are asked on the complications that are caused by ulcerative colitis as well. The most common complication for ulcerative colitis is toxic megacolon, where you'll find that the bowel has been dilated and is tender, has not got any movement, but it is dilated for more than 6 centimeters, please. One of the most important association of ulcerative colitis is association with the skin. This is not usually asked in the answer, but it is mentioned in the question that erythema nodosum is the most common finding in the question you will find with patients who are having ulcerative colitis. Next, I want to talk about pyoderma gangrenosum, where you find questions based on the clinical scenarios saying that this patient has got ongoing diarrhea. Now the patient has got multiple lesions where they coalesced and formed a single lesion, that is pyoderma gangrenosum. Patient has got redness of the eyes. What do you think of? It is episcleritis that you will need to think of. And then we talk about spondyloarthritis. Whenever we talk spondyloarthritis, it is easily mentioned that the patient will have pain, but the patient will also have stiffness, which usually resolves towards the end of the day. So diarrhea with stiffness, you think of spondyloarthritis. Sclerosing cholangitis, you'll have to think of a male patient having ulcerative colitis. If a female patient, it is primary biliary cirrhosis. Very classic question for USMLE step 2. Next, we screen ulcerative colitis. The point of asking ulcerative colitis and colorectal cancer is the examiner wants you to understand that you will do the colonoscopy for patients. So whenever you find ulcerative colitis patient, please do look for option saying that this patient has got to undergo a screening with colonoscopy, and that to annual colonoscopy screening is what we'll have to do. Whenever you talk about the colonoscopy and colorectal cancer and ulcerative colitis, you will have to start screening the patient for colon cancer beginning at 10 years, or 8 to 10 years to be more specific, after the initial diagnosis. When we talk about ulcerative colitis, I want you to understand in the question, they will give you the biopsy findings as crypt abscess, and there is leukocyte distribution in the layers of mucosa and submucosa. Whereas in the part one, the question will be framed as what is the most common finding. You will have to understand it is the crypt abscess that you will see in ulcerative colitis. Next, we talk about Crohn's disease. It is the complete involvement. I want you to understand that ulcerative colitis is ulcer, so it is spreading. Crohn's disease, the stem in the question, you will find that the patient has got involvement of any of the part of the gastrointestinal tract. But this patient will have history of smoking in the question for Crohn's disease. Whereas smoking is a protective or a preventive agent for ulcerative colitis. Remember, whenever the patient has got painful anal fissures are painful. Basically, whenever the patient has got pain while passing, or pain with constipation, think of anal fissures. Patient will not go to the washroom. if the patient has got Crohn's disease, because there is so much of pain given that the patient will also develop complication of Crohn's, that is anal fissures. In the examination question, you will find anal tanks. But if the examiner wants you to test the difference between ulcerative colitis and Crohn's disease, you will understand that fistulas are the first most important thing you'll have to answer in the question whenever the examiner is examining you on Crohn's disease, because fistulas are the most common thing that develops in Crohn's disease. But why are we talking about fistulas, leaving all the important stuff? Because the examiner wants you to understand that MRI is the investigation of choice whenever the patient develops fistula in Crohn's disease. It is no more a colonoscopy, it is no more a imaging CT scan. It is the MR scan whenever the patient develops fistula. Remember, in abdomen, if there is inflammation, CT scan is the ultimate diagnosis, ultimate imaging that you will have to do. That is why diverticulitis, we use CT scan. For the abscess, we use CT scan. All right. In the question, you find that patient with fistulas will also have predisposition to aphthous ulcer. Without aphthous ulcer, there is no question on fistula. If the fistula is from Crohn's disease, that is how you will have to identify Crohn's disease fistula. Remember, MRI is the investigation of choice. Next, we talk about extraintestinal manifestations where arthritis, skin lesions, and lung diseases are common. But the confirmatory diagnosis is by microscopy histology where non-caseating granulomas are seen. Sometimes patient with Crohn's disease will develop recurrent vomiting, and this usually happens in patients who are young. Whenever young patient with Crohn's disease comes with vomiting in the question, examiner wants you to understand that this patient has got strictures. Remember, in general, if the patient has not got any strictures, surgery is the most common cause for small bowel obstruction, because surgery causes adhesion of the small bowel and small bowel obstruction can develop adhesions. Whenever the patient has not got any Crohn's disease, it is the adhesions and the small bowel obstruction that is the most common answer you'll have to select. But if the patient has got Crohn's disease, it is the stricture that you will have to select. And the initial step is endoscopy or colonoscopy you'll have to do. Biopsy is the most important finding you will have to answer when they ask about the definitive diagnosis. I also want you to understand the differential diagnosis for Crohn's disease is an infection, that is tuberculosis. But in tuberculosis, it is the caseating granuloma that is formed. The tuberculosis affect the ileocecal part. So cecal ileitis or ileitis can also be caused in both Crohn's disease and tuberculosis. However, it is only with the biopsy that Crohn's disease and tuberculosis can be differentiated. In Crohn's disease, when you see, there will be transmural inflammation, whereas in tuberculosis, there will not be any transmural inflammation. When you treat or consider treatment for Crohn's disease for USMLE step 2, if it is exacerbating, it is corticosteroids that you will have to use. If it is a systemic symptom, if it is not exacerbating, you will have to use 5-amino salicylic acid. Basically, amino salicylic acid is the first line. For exacerbation, it is corticosteroids, it is the first line. You can also have additional therapies such as azathioprine and anti-TNF therapies as well. Remember, in the question on endoscopy, you will find cobblestone appearances. There are skip lesions, there are strictures. But the stricture is usually the answer whenever the patient has got vomiting with Crohn's disease. And in the question, you will find that there is cobblestone appearances previously on the colonoscopy or the endoscopy. Remember, this is an inflammatory disorder, so inflammatory marker will be raised. Now, talking about the difference between ulcerative colitis and Crohn's disease, I want you to understand that on biopsy, there is non-caseating granulomas in Crohn's disease, whereas there will not be any granulomas in ulcerative colitis. And Crohn's disease starts with C, so it can involve completely. C, completely. That is what you'll have to remember. Ulcerative colitis, rectum is the most common organ that is involved. Ulcer spreads, so it is a continuous lesion, whereas Crohn's disease, it is a skip lesion. Crohn's disease can affect muscle, whereas ulcer will not involve the muscle. So there is only mucosa and submucosal involvement seen in ulcerative colitis, whereas no transmural inflammation is seen, whereas pseudopolyps are seen in ulcerative colitis. I also want you to understand that Crohn's disease, it is the transmural inflammation and cobblestone appearances that can be seen. When it involves the muscle, it causes abdominal. Welcome back again. So, if it is a transmural inflammation, remember Crohn's disease causes abdominal pain. Whenever there is abdominal pain in Crohn's disease, it is usually the right lower quadrant that is involved because ileocecal or cecal ileitis is the most common presentation. In ulcerative colitis, it is an ulcer, so ulcer bleeds and there will be bloody diarrhea. Whereas in Crohn's, only bloody diarrhea is seen if there is inflammation of the colon, that is colitis. The most important thing and most important differential things you will have to remember is for ulcerative colitis in the question is framed in such a way that the examiner is looking for you to answer toxic megacolon as a complication of ulcerative colitis. Whereas in Crohn's disease, it is the fistulas, it is the abscess, it is the strictures, it is the MRI scan that you will have to choose as an answer for complication of Crohn's disease. Remember, everyone knows about ulcerative colitis and everyone knows about Crohn's disease. But what I want you to understand for USMLE step 2 is they will not test you on general presentation of ulcerative colitis and Crohn's disease. It is always the complications of ulcerative colitis and Crohn's that you will be tested on. And I also want you to understand and remember the investigation of choice for the complications as well, please. Next, we talk about screening of colon cancer in patients with IBD and in normal patients as well. Whenever I see a patient at age 50 who is coming to my clinic and has got an average colon risk, or whenever the patient is young who is 40 and has got a family history or a first degree colon cancer history, I want to screen them. Very important. I want to screen with a stool occult blood testing that is done annually. And I also want to do a new test that is fecal immunochemical testing. And this test, I want to do it annually. Remember, this is the first most important test. Remember, patient comfort is always the most important thing you'll have to remember whenever you're practicing clinical medicine. Do not do colonoscopies, do not do fancy test. Do a simple blood test, do a simple stool test as the first investigation. Whenever you want to confirm it, you will have to see it. So you select the colonoscopy. You can do visualization techniques or you can do colonoscopies or endoscopy techniques, but you will have to do it every 10 yearly. Whereas stool testing can be done annually. Whenever you think that the sigmoid colon is involved or the patient's family history has got a significant involvement of the sigmoid colon, please do flexible sigmoidoscopy every 5 years. But if the patient has got high risk of colon cancer and patient wants you to screen very aggressively, you can do flexible sigmoidoscopy every 10 years. And you can also do fecal immunochemical testing or fecal occult blood testing annually. Remember, in the question, it is the fecal immunochemical testing annually that you will have to select if you think that the patient is at risk of colon cancer. I also want you to understand that patients with adenomatous polyps, I want you to screen at the age of 40 or at the age of 10 years before the diagnosis of the family that is affected. Whenever there is inflammatory bowel disease, it is 8 to 10 years or 10 years, you'll have to do a colonoscopy after the initial diagnosis. And the most common question the examiner will ask you is when do you want to repeat colonoscopy in patients with ulcerative colitis? It is 1 to 3 years, please remember this. In patients with the Lynch syndrome, please repeat the colonoscopy every 1 to 2 years. I want you to understand that Lynch syndrome, you'll have to do the CT scan of abdomen or endometrial sampling in order to rule out endometrial cancer. That is what the examiner will be looking for. Hmm. I don't know if you're able to see the screen or not. Just let me know. Next, we talk about I don't know, something crazy is happening. I don't know if you're able to see the screen. Okay. Oh, whenever I talk about inflammatory bowel disease, basically, I also want to talk about irritable bowel syndrome here. Remember in the question, if the patient is a young woman who is less than 50 years of age, but the most important thing is this patient has got history of anxiety disorders, history of depression, history of psychiatric problems, history of fibromyalgia, and is on steroids. Then you will have to think of irritable bowel syndrome. Remember, the patient will have recurrent abdominal pain at least for more than 1 day in a week and for the past 3 months. That is the diagnostic criteria of irritable bowel syndrome. Remember, there will not be any question on irritable bowel syndrome if the examiner has not given you this statement. Recurrent abdominal pain or recurrent abdominal discomfort for more than 1 days every week for the past 3 months. This is the diagnostic criteria of irritable bowel syndrome. I want you to understand irritable bowel syndrome is not. I want you to understand that irritable bowel syndrome is not a problem until the patient develops rectal bleeding or until the patient has got diarrhea, which is waking him from sleep. Remember, irritable bowel syndrome with weight loss is a warning symptom. Irritable bowel syndrome with anemia or with abnormalities in the electrolyte disturbances is a problem. Remember this, please. Whenever the patient has got irritable bowel syndrome, remember the patient can have constipation or patient can have diarrhea. Whenever it is the constipation, you will have to select fiber supplementation as the most important option. Whenever it is diarrhea, we all studied that it is the symptomatic management with loperamide. Next, we talk about screening or upper gastrointestinal bleeding. Upper gastrointestinal bleeding patient is usually young patient, alcohol, recurrent vomitings, patient presenting with abdominal pain, hematemesis, sometimes patient present with melena. Please think of upper GI bleeding. It is the ligament of the treats that determines if it is an upper GI bleeding or a lower GI bleeding. If it is proximal to ligament of treats, it is defined as an upper GI bleeding. If it is distal to ligament of treats, it is the lower intestinal bleeding. But remember, in the question, the patient will present with abdominal pain and hematemesis. Whenever the patient has got tachycardia, your differential diagnosis in the question while reading the question must be dehydration, must be infection, must be hemorrhage. Very important. These are the three most important things you'll have to remember. Whenever the patient is obese, whenever the patient has got a recent surgical procedure that is done for obesity or a bariatric surgery that is done for a uh, bariatric surgery that is done for obesity, and the patient has got a gastrointestinal leak, how do you identify in the question? It is the pulse rate that you will have to look for. Any pulse rate who is got a tachycardia of more than 100 must not be neglected. You'll have to think of differential diagnosis. Differential diagnosis for USMLE step 2 for tachycardia in the question whenever you find is dehydration. In the question whenever you find it is the infection. In the question whenever you find a bariatric surgery, it is the anastomotic leak. It is the hemorrhage whenever you find a patient with road traffic accident. It is the hemorrhage whenever you find a patient with fall and alcohol or multiple falls. It is anemia whenever you find a pregnant woman, menstruating woman, elderly woman with weight loss. Tachycardia is suggestive of anemia. Patient with celiac disease, patient who is developing iron deficiency anemia can only have weight loss and tachycardia. Please think of iron deficiency anemia. I want you to understand that most of the things for tachycardia must not be neglected. Say, for example, the blood pressure. Whenever the blood pressure is 140 by 60, which is unusual because 120 by 80 is normal. But whenever it is 140 by 60, I want you to understand that the diagnosis is aortic regurgitation. I want you to understand that if the patient has got Marfan syndrome, it is the aortic root dilatation that is setting in. I want you to understand whenever you see a patient in the question, the examiner is mentioning the blood pressure of 140 by 60, you will have to understand that it is the aortic regurgitation that is setting in. It is the aortic root dilatation that is setting in. This type of values must not be missed. Please do remember this. Very easy to answer and it will save you a lot of time. Next, coming back to upper GI bleeding, sorry that I have off tracked, but tachycardia is one of the most important finding for upper GI bleeding. I also want you to understand that whenever the patient is on blood thinning medication and whenever the patient complains of retrosternal pain, the patient has got tachycardia, patient has got hypotension. I want you to understand that this patient has got developed that this patient developed a peritoneal bleeding. Retroperitoneal bleeding is a concealed bleeding. It is only identified by the retrosternal pain or retroperitoneal pain or a back pain, which is dull ache. Patient presents with flank pain sometimes. Patient presents with hypotension whenever there is retroperitoneal bleeding. It is a concealed bleeding. So the next most important thing you will have to do is CT scan with contrast is the investigation of choice for retroperitoneal bleeding, which is a concealed bleeding. It usually happens in the pouch of Douglas. So it is hard to examine pouch of Douglas. Remember, for acute GI bleeding, whenever you do lab values, you will find acute anemia. You will find that the patient will have acute kidney injury. You will understand that there is increased creatinine and increased urea on the bloods in the question. Whenever there is upper GI bleeding, if the patient is hemodynamically stable, that is, the blood pressure is more than 90 by 60 or 90 by 80 or systolic blood pressure of more than 90, I want you to do supportive management, please. Two large IV cannulas, oxygen and bowel rest. You'll have to make sure that the patient is on IV proton pump inhibitors. I also want you to understand that group and save is the next most important option you're selecting in the main exam. You'll also have to request packed cell RBC if the patient has got low hemoglobin. If the patient has got hypotension, the first step in the management is two large IV cannulas with IV crystalloids, please. Very, very, very important. You're not going to the exam if you're not knowing this. If the patient has got severe hypotension, please select a blood transfusion as the most important thing you'll have to do. If the patient has got acute anemia, please select the blood transfusion as the important next step, please. Because red blood cell can cause volume expansion in the body as well. Next, I want you to understand perrectal bleeding management. Whenever there is perrectal bleeding management, I want you to ask if the patient has got any pain or not. If the patient has got pain, please do not do a perrectal examination. Also, whenever the patient has got a red blood on perrectal examination, you will have to understand if the patient has got any red flags or not. If the patient is elderly and have the patient and has red flags such as weight loss, such as bleeding per rectum, you will have to do a colonoscopy. If the patient has if the patient has not got any red flags and if the patient is a young patient, you can visualize the anus. You are looking for any hemorrhoids or you are looking for any other source. If the patient has got hemorrhoids in young patient, no red flags, you need not do anything. But in the options, in the question they frame, the patient is very young, that is 31-year-old gentleman presented with painless bleeding, and on the rectal examination, you find blood staining on the finger gloves. What is the next most step? Direct visualization is the first most important step. Best next step is visualization. If best next step, such as visualization, is not present, you will have to do an anoscopy. Look at the anus. You'll find hemorrhoids, don't do anything. If you do not find anything on anoscopy, please do a sigmoidoscopy or a colonoscopy. There is a group of patient where the patient does not fall in between young age and old age. They are middle age patient, 40 to 50 years old. But this patient has not got any red flags. What do you do? Please do a sigmoidoscopy as the first step. Later, you can do colonoscopy. Very important. Next, we talk about diverticular diseases. My most favorite question for diverticular diseases is the patient will not have any symptoms in the question. It is diverticulosis that is the answer. Whenever the patient has got diverticulosis, it is because the patient will have increased intestinal pressure. That is why the patient will have diverticulosis. Whenever there is diverticular bleeding, it is because of the vasa recta that is involved. Whenever there is diverticulitis, it is the inflammation because of the obstructed food particles that is happening, and this obstructed food particles which leads to microperforation will have diverticulitis. So CT is the investigation of choice for diverticulitis. Whenever you find diverticulitis or diverticulosis in the question, the patient says, the examiner says that a white patient is having diet which is rich in red meat, diet which is low in fiber. Low in fiber is the answer, but red meat is, you'll find it in the question. Patient BMI is more than 30, that is obesity. Patient plays video games. Patient is physically inactive. Patient does not exercise. Patient has got a history of 10 cigarettes per day, that is smoking, diverticular disease, obesity. Please think of diverticulitis. If the patient has got fever, again, fever and abdominal pain, is diverticulitis. One of the differential diagnosis, not a differential diagnosis for a contralateral or a sister diagnosis for appendicitis. If it is a right lower quadrant pain with the fever and tenderness, it is appendicitis until otherwise proved. If it is fever with tenderness and in the left lower quadrant pain, it is diverticulitis, please. Young female patient with tenderness in the right iliac fossa during menstruation, please select endometriosis as the option.